We have our very own Dr. Lana Rezan Abdulaziz, who has a Arab board in radiology and I believe also an Arab board subspecialty in breast imaging. She'll talk about the role of ablation in multiple benign breast masses. فرمي دكتورة. عليك السلام. وش بوينترا؟
I'd like to thank you all for attending, and thanks for all who contributed to make this event possible. I'm very certain that many of you had heard the word ablation these days frequently, and it become a point of interest for many subspecialties. Today I will put the light on this new invention in breast imaging and how we select our cases. So what is ablation? These are the frequent method of ablations that have Actually, the patient will present with multiple visits. They feel more anxious with the frequent visiting and follow-up. Sometimes when these masses become large, the shape of a breast becomes deformed and cause discomfort to the patient. Sometimes they will feel heaviness and stretch nipple areola complex and the skin. They end up with frequent surgeries and multiple scars. So some notes about multiple benign breast masses. About 16% of cases present between age 20 to 30 years old. In our center, we have about 3 cases per day. Usually, the etiology behind these multiple masses is the sensitivity to hormones, and it may enlarge during lactation and the pregnancy, may associated with family history or some syndrome. The problem with fibroadenoma that it increases the risk of breast cancer by 1-fold, especially when it is large and when it is associated with other hyperplastic changes such as sclerosing adenosis. And the risk of cancer is about 0.002. This is an image of MRI, and as you see, multiple enhancing masses, which appear circumscribed, and the masses here may reach up to 5 centimeters. Here we call them giant or juvenile fibroadenomas. So in general, what are the minimal invasive procedure that is available for breast nowadays? These and the indication for them, usually they do it for benign breast masses, for young ladies with multiple fibroadenomas. And in some centers, they do it for malignant lesion, especially if they are not candidate for general anesthesia, if this invasive ductal cancer is T2 without nodal involvement. But here in our center, we don't do it for malignancy. We do it for, if the case is not candidate for GA, they will do it by, we do it by local anesthesia. In our center, these are the available invasive procedure now, which are the ablation, microwave ablation, and the vacuum-assisted biopsy. And it's well known the advantage of minimal invasive procedure over the traditional surgery regarding the scar, the cosmetics, and hospitalization. This is an example of cryoablation in breast cancer. Not our case, but in that image you see the small cancer on mammography and on ultrasound. After cryoablation, they put a clip before cryoablation inside. And you see the tumor is totally vanished, and only the reaction to the cryoablation remain in the surrounding tissue. So how we prepare our cases for microwave ablation? Of course, we select our cases through MDT, and we exclude chronic disease, lactation, and pregnancy. We do some pre-procedural investigations. During the procedure, we use local anesthesia, move and shoot technique, and after the procedure, we give painkiller, and we follow up our cases. So how we select our cases? Of course, the ultrasound is the standard, gold standard for the diagnosis, and we depend on the Stavros criteria in which the risk of malignancy is essentially 0. So the criteria for benign masses by ultrasound is when the mass is oval, circumscribed, homogeneous, we have echogenic rim around the mass, we have posterior enhancement, and the mass is parallel to the chest wall. In these cases, we can say that there is no chance of malignancy, and we can proceed to ablation in these, with these criteria. And by MRI, we have what we call it a Kaiser score. We define the feature of these masses according to map and according to the score, and it will help us to decide the whether the mass is benign or not. As you see, there are bilateral benign masses, and the indication for MRI in multiple benign masses is to make a map, surgical map, if the patient decides to do surgery, or to see where are the remaining tissue, how much remaining tissue that the surgeon should avoid during the surgery. A role of mammography in benign masses, or actually in fibroadenoma, is just when we have microcalcification, because mammography cannot differentiate between cyst and solid, and if we see a calcification within the mass by ultrasound, we should proceed to mammography to assess the type of calcification. As I said, the ultrasound is the gold standard technique to differentiate simple and complex mass, and I will show you some features of benign, complex masses that we actually avoid to do microablation for these cases until we do biopsy for them. For example, in the image on the right side, we have some blurring along the lateral wall. This is a macrolobulated mass. Sometimes the mass is heterogeneous, and sometimes show cystic changes. Sometimes we have extracanalicular extension. And when the border of the mass is not clear cut, not very circumscribed. And when we have a cystic changes more than 3 millimeters within the mass. So the problem with complex fibroadenoma is because there is risk of cancer 2 times as compared to simple fibroadenoma. And we should be aware about the masses with the lactational change, because during lactation, these milk will produce inside these mass, and it will give it a complex feature like the image on the left. And actually, these are just a benign mass with lactational change. This is a paper published by our team, and as you see in the picture, fibroadenoma for more than 15 years now involved with malignant type microcalcification. So the role of mammography is very important in the microcalcification. We have other couple of cases. These are large or giant fibroadenoma in teenage girls. The image on the right side, you see a large fibroadenoma that show a necrotic center when it become large, and may show a necrotic center. And very confusing when a young lady came with a large mass, and it was actually sarcoma. So we should be aware about this point. Another mimics for multiple fibroadenomas are metastasis to the breast. In this case, she had the neuroendocrine tumor from lung, and she presented with multiple masses in the breast that shows a complex feature, and biopsy reveal multiple breast metastases. Again, fibroadenoma in axilla may mimic an abnormal lymph node because there is no hilum and it appears as a small abnormal lymph node. And this is another paper published by our team about fibroadenoma that mimic carcinoma, يعني lymphatic lymph node involvement by cancer. This is our cases. These are example of our cases, microwave before and after. As you see, immediately after the procedure, it becomes shrinked. And this is another case, become heterogeneous and immediately become smaller in size. During these few months, from February to June, we ablated about 57 masses. And when the masses are small, we see a rapid effect of ablation on these masses. About 16 of them immediately obscured, and about 33% of them after immediately had a response. And this is post-procedural follow-up. The mass become smaller, become more heterogeneous, and this is another example. So, conclusion to microwave ablation, it is a very good alternative tool to surgery because of excellent cosmetic and low complication rate, but the selection of the cases are very important. So, young lady with large masses, we can do microwave ablation immediately using Stavros criteria, while older ladies, masses with complex feature, we should do a biopsy and then microwave. Thank you.